tell me, right? So then we can correct if there's any issues while doing the lecture. Uh, Actually, subfertility lecture is very important because you know that the subfertility in gynecology is a kind of another discipline. So we have at the moment in Sri Lanka, we have 3 consultants with subfertility specialists, right? So, so that shows that subfertility is a kind of vast area, even though it is incorporated into gynecology. Because of that, you have to know about the subfertility very well. And I would say like 1/4 of the gynecology is the subfertility. Here, so it is a big problem at the moment because you know that the incident, worldwide incident, there may be geographical variations, but worldwide incidence is around 10 to 15. That's mean 1 out of 5 people can have, couples can have problem with the subfertility, maybe primary or secondary. So that is the magnitude of the problem, but it is in increasing trend because of the uh, uh, environmental factors. Uh, Now it is increasing in trend. Uh, so in this lecture, so I'm going to touch upon what is primary and secondary subfertility. So what are the investigations we should do? What kind of uh, knowledge and what kind of care we have to give in primary and secondary care level, and the different advanced reproductive technologies. So definition of the subfertility is the failure to have a conception for a couple having regular unprotected sexual intercourse for 1 year, provided that normal intercourse is occurring not less than twice a week. But the secondary subfertility is different, so that is we take as a 6 month. So, but in primary subfertility, it's a 1 year. Secondary subfertility is 6 months. So here, this slide, it will show that the natural conception rate. So what you have to understand is, so if you take 100 couples, 80% of them will get pregnant after 12 cycles. 12 cycles means 1 year time. If you wait for another 1 year, 50% of remain who did not have conception, that's mean 90%. Cumulative rate is 90% at the end of 2 years. Then if you wait without any treatment for another 4 years, another 50%. That's mean by the end of the 4 years, 95% of them get pregnant naturally without any interventions. But who is happy to wait for 4 years? 2 years? No, because you know that it is a social stigma. There are so many social stigmata, and it stresses family, social, personal, couple per se. So if you know, sometimes people coming in 3 months time when they get married, newly married couples, if you don't get pregnant in 3 months time, they come for a treatment. Should we start treating them? No, because so what we are doing is a treatment, also intervention. So then any interventions can have problems. So then you have to allow them to have natural conception for a while. So that is why, so we are selecting, we are waiting up to 1 year, because the maximum amount of couple get pregnant, that's mean 80% in 1 year time. But if you wait, if there's no issues, if you wait for 4 years, 95% of them get pregnant. But the 1 year is the cutoff. You can understand the rationale behind that. Right. So here I'm going to talk about the primary and secondary subfertility. So primary subfertility is a couple without a prior pregnancy or pregnancy outcome at all. So that is primary. Secondary subfertility, couple with a previous pregnancy. It may be a live pregnancy, it may be a miscarriage or ectopic. So if they don't get conception, failure to get conceived after some kind of pregnancy outcome, that is called secondary subfertility. Primary subfertility take 1 year, secondary subfertility take 6 months. Ecological wise, if you are going to talk ecological wise, uh, there may be a male factor, female factor, mix. That means both has to be responsible, and there's a 20%. That's 1 out of 5 people can have unexplained fertility issues. So that is how we categorize etiologically subfertility. Is this clear now? So sound and all clear?
Yes, sir.
Right. So then we will talk about the etiological factor in males. So as I said, the 1/3 of reasons may be due to male factor. Basically here what we are going to talk about, basically male factor, you know that the sperm quantity and quality. So that is a major concern. So in addition to that, there may be some sexual dysfunctions and anatomical problems. So the sperm problems, so majority of the people can have problems due to environmental and occupational related sperm quality and quantity have problems. Oligozoospermia, keratozoospermia, actinozoospermia. There are different words we are using for that. So they are the primary problem may be hypogonadotrophic hypogonadism. That is from the primary level. That's means from the higher center onwards there's a problem. So they will have atrophic testes. So then primarily, they don't produce sperm in the testicular level. Now, another thing is obstructive azoospermia. So they are producing sperm, but there's some obstruction in the pathway, outflow tract. This may be due to some infection, previous infection. This may be a trauma. This may be a surgical, that is intentionally causing like a following surgery, complicated surgery, and erectile dysfunctions. The anatomical, that's been hypospadias, so they can't engage and they can't ejaculate properly. So undescended testes, mal-descended testes. So those are the things that we have to look for in the male. So females, so usually when we talk about the female, we have to consider 3 things. One thing is the major thing is ovulation. Is there an ovulation dysfunction? So second thing is there are tubal problems, and third one is there any anatomical problem in the genital tract? So here the majority, the endometriosis and subfertility has a big association. So if you take a couple, the female partner with the subfertility, so you can find 40% of them can have peritoneal factors. For example, endometriosis in very mild, moderate, sometimes subclinical. So why we talk about peritoneal factors? Because you know that so usually the gametes release to the peritoneal cavity. So then with the endometriosis and environment, endometriosis and PID, so this can cause poor quality gametes, and then subsequently they don't get conception. So we'll talk about endometriosis and subfertility separately. So when you are learning about the endometriosis, we are going to talk about the endometriosis and subfertility separate this thing. So here, so I will just tell you that endometriosis is one of the major reasons. So somebody having subfertility, that's why. So laparoscopy is invalid. Then tubal blockage. 20% of people, the females, can have tubal problems. So then it may be a functional or it may be a anatomical. You know that the tube to be function properly for the gamete transfer, you need to have a proper function, that is a ciliated mediated unidirectional the function. So if the ciliary surface is damaged, so then this transport mechanism is having problems. So then sometimes they don't get pregnant, or some people can have ectopic pregnancies because of ciliary dysfunction. Then the anatomical wise, it can be the true block or pseudo block in the tube level. So then it disturbs the traveling of the gametes and embryo, fertilized embryo. So the tubal blockage, so 1/5 of them can have tubal problems. But so you have to remember that this is in primary subfertility, but secondary subfertility tubal blockage is much more higher. It is around 30 to 40%. That is double the risk of tubal problem in secondary subfertility. So in females, so we talk about the male factors. Then we are going to talk about the female factors. In the peritoneal factor, then ovulating dysfunction is the major thing, that is around 120%. So the ovulating dysfunction, the major cause of ovulating dysfunction at the moment is polycystic ovarian syndrome. So 20% of the population, young people, can have polycystic ovarian syndrome. It may be clinically apparent or clinically not apparent. So they will have ovulating dysfunction. So they are having oligo ovulation and ovulation cycles. So, and in addition to that, they can have primary level problems from the hypothalamic level or hypothalamic level or pituitary level. Then ultimately that can manifest hypothalamus ovarian pituitary axis dysfunction and having ovarian dysfunction. Then ovarian failure. So ovarian failure is premature menopause kind of thing. So that is happening usually ending ovarian reserve before the age of 40 is called premature ovarian failure. So then ovarian get failed, so they don't produce gametes, or infrequently they produce gamete. One of the example is Turner mosaic. So they initially produce gamete, later on they don't produce. But sometimes ovarian failure can happen due to iatrogenic factors such as chemotherapy, radiotherapy, and drug-related failure. The uterine cavity abnormalities. You know that uterine cavity can get abnormal due to congenital issues or iatrogenic or acquired things. So then if it disturbs the cavity, the normal function of the cavity and distortion or cervical level, so then the transport mechanism, the transport of the sperm and the embryo implantation is defective. So ultimately what happens is, so they will have subfertility. So Asherman syndrome, you know that is excessive curettage of the endometrial surface up to the basal level, damage to the basal layer of the endometrium, causing adhesions formation within the cavity, and that is iatrogenic. And then uterine fibroids, as I mentioned, like endometriosis, fibroid has a controversial effect on the subfertility. So basically, we know that any fibroid which distort the endometrial surface is the main culprit causing subfertility. But in addition to the big fibroid increase the endometrial cavity without distortion also can cause. But the main issue with the submucosal fibroid. Other fibroid, lesser extent responsible, but submucosal fibroid which disturb the ovarian, the uterine cavity is the main culprit. Then you know that congenital problems like bicornuate uterus, uterine diabetes, so unicornuate uterus, so they are congenitally abnormal. So usually they will have primary subfertility, or if they get pregnant, so they can have early miscarriages or preterm labor. Then cervical factor. Cervical factor, so with the cervix, you know that they produce cervix and produce immunoglobulin, that is antibodies. So that antibody can damage sperm. So that is called cervical hostility. Infection, if there's an ongoing infection, like chlamydia, monococcal infection can damage the cervical integrity, and that can cause cervical factor subfertility. And sometimes, so we talk about the cervical stenosis, but you know that sperm is a very tiny structure. You have traveled with the tiny holes, but the severe cervical stenosis due to surgical intervention damage to the cervix infection may be responsible for cervical factor subfertility. So here, so up to now, what we discussed, so I'm going to summarize you to that and you to wind up what we have talked about up to now. So we talked about what is subfertility. So I rationalize the subfertility with the duration. So what is this natural conception rate? When we are going to tell they are subfertile, and then we talk about the definition, and then we talk about the physiological factor, male factor and female factor. Male factor, basically we talk about the sperm quality and quantity. So hypogonadotrophic hypogonadism, primary dysfunction of the production of this thing, sperm, and then the obstructive S2 sperm, the block of the outflow, and then sexual dysfunctions. Then other congenital problem in the male partner. Then female partner, basically I talked about ovulative dysfunction, tubal and genital tract abnormalities. Those are the three things in female factor. Remember, tubal factor, block or functional defects, ovulative dysfunction due to different issues, but I said the polycystic ovary syndrome is the main culprit, and uterine cavity or genital tract abnormalities, congenital or acquired one, and cervical hostility. Those are the main four things responsible for female subfertility. So, as you know that any chronic disease can cause subfertility, like dual control diabetes, thyroid dysfunction, renal disease. So it is generally, so it alter whole body. If it's whole body issue, then most of them are subfertile unless it is well controlled. So history taking. So then now you have a basic idea what are the reasons. So now how we manage them clinically. So when the couple is coming to you, so first of all you have to decide whether you are going to investigate them or not. So some, as I said, some are coming in 6 months time, 3 months time after marriage, but you have to counsel them, take a brief history from both partners and see whether there are any issues in their history. If there's no issue, reassure them and send them back, ask them to come in 1 year time. Tell that there's a high chance them to get conceived within that period of time. And then so if they want treatment, so then that's mean 1 year later, or if they are having already having a problem, so then you have to start treating them. Then the history taking is very important. So you have to take history from female partner and male partner. So you have to ask for the symptoms, what are how long they are waiting, or how frequently they are engaging the coitus, and any history of previous history of STI, PID. So that can cause genital tract problems, tubal factor subfertility, and the peritoneal issues, and then sexual dysfunction. So galactorrhea is one of the presentation of hypoprolactinemia. Thyroid function because so currently there are so many people with thyroid dysfunction that if it is poorly controlled, they can have ovulating dysfunction and subfertility. Then obstetric history for the subfertility. So very important menstrual history. So you have to ask about when was her last period, how regular, is there a menstrual related issues that will reflect the pelvic pathology like a dysmenorrhea, dyspareunia, then international bleeding, heavy menstrual bleeding, whether it is regular, irregular. So very good concise sexual history is very important. So menstrual history very important. Then surgical history, as I said, sometimes surgeries in genital tract can damage cervix, uterine cavity, and even tubes. So DNC. So if you do indent DNC, that can damage the basal layer of the endometrium, ultimately causing adhesion inside. Then any abdominal or pelvic surgery, it would touch upon internal structures like ovaries and tubes, so that we can have, so with that, so we can have adhesions, because we know that any organ inside the body, if you touch excessively, so there is a chance of adhesions to it. So the ovaries are nasty organ, right? So most of the time, if you touch upon the ovaries, there is a chance of adhesion forming, and that will supply the badly affect the fertility, because of release and pick up, and these things will be affected. Any contraception previously used, you know that you see the DMPA, you know that the use of DMPA can delay the conception 6 to 9 months. So if somebody wants to have a child pregnancy, so discourage DMPA, but OCT and other contraceptive is so readily, when you withdraw the contraceptives, they are readily fertile from next cycle onward. Cervical HCA is important because it is an opportunistic situation. If you ask about cervical HCA, that is actually screening test for the cervical malignancy. Male, so you have to ask about, as I said, to find out whether there are any related biological factor, any childhood history of infection, mumps, bronchitis, prostatitis, any trauma, any surgeries, hernia repair, testicular surgeries, any surgeries done for prostate or varicose. So then it can damage the outflow tract and cause obstructive vesicular. Yeah. So then occupational history, as I said, the most of the time at the moment, even though there are no other the obvious physiological factor, but the environmental factor is a lot more responsible for male factor subfertility. So what kind of job, occupational history, whether they are exposing to different toxic agents, heat, and things are very important in the physical. Then drug history, you know that these are very important to know that even your MCQs, the drugs can cause impaired spermatogenesis. So sulfasalazine, then antipsychotic drugs and immunosuppressant, those are drugs responsible for the impairment of the spermatogenesis. Then, even though this is not very prominent in our society, smoking, alcohol intake, psychological factors. Smoking and alcohol intake in male partner is you have to ask, but female partner is not a obvious thing in our society. But male partner you have to ask, because this is badly affect the fertility of the couple. Psychological factors. So this is not directly responsible, but you know that fertility issues in the family. So we have a nucleus family. So there are the 3 generations living together most of the time, and then somebody don't have children. So then family pressure as well as the social pressure is a problem. So then they are psychologically depressed. Some people with psychiatric issues also, and so taking the psychological aspects of their couple is very important. And so then you have to you can arrange subsequent psychiatric counseling, psychiatric treatment, and these things if you are having these psychological capacities. The important thing you have to ask about the psychological impact issues surrounding the fertility different. So then examination. So you have to assess what is general nutrition status, what is their body habitus. The body mass index also important because body mass index is the underweight and overweight is responsible because underweight both situations they can have the ovulatory dysfunctions and sometimes even they get pregnant because there is a chance then to have miscarriages. So underweight and overweight both are not good for the for the fertility. So when you first encounter this couple, so then you have to start with this general measures. If somebody is underweight, so you have to advise on proper nutrition. Overweight, so you have to refer to dietitian and other relevant people for the weight management. Other specific diseases you have to ask for hirsutism. Hirsutism, you know that there are some people can have late onset congenital adrenal hyperplasia and the galactoria in case of hyperprolactinemia. Then the bimanual examination to assess the adnexal masses, tenderness in case of PID and endometriosis. Then uterine enlargement with the fibroids is important. The important examination you have to carry on with this kind.
Excuse me, sir.
Yes.
There's something disturbing in the background to the voice.
That means it is not clear.
Not sir, it's not clear.
So it is a long time issue or not just now started?
It's been for a while, sir.
So you can't hear properly. That's me.
Yes, sir.
No, you have to tell me.
It's like something humming in the background, sir, like a fan or something.
Yeah, so I think that is, of course, my computer fan is running a bit fast. I think that is the one that disturbing. Is there any improvement? Hello? Hello?
Hello, sir.
Yeah, is there any improvement of noise now? Hello? Can you hear now? Hello? Hello? Yeah, my voice is clear now. Hello?
Yes, sir, it's a little more clear than before.
Bit clear now?
Yes, sir.
Okay. Shall I carry on?
Maybe it's easier if you speak into the mic like that.
Yeah. So I will speak to the mic. Yeah, you have to tell me, right? Otherwise, I think that you are comfortably listening. Right? You have to tell me, is there any disturbance? You have to tell me then. Okay. Yeah. So then the male factor. So examination. So you have to see the testicular size and presence of varicocele and hernia, size of the prostate. Is there any gynecomastia? These things you have to look in the male examination. Right. So then referrals. So if you the primary level. So if you find somebody having female partner having these factors like age more than 35, that's my elderly. Is there a history of menstrual dysfunction? That's suggestive of the ovulation of ovulation or pelvic disorders like history of PID, any abnormal pelvic examination. So then you have to refer them early for the secondary level management. Then main fact, if you find any abnormalities in the examination and history, then both partners, somebody waiting for chemotherapy and somebody having any bloodborne diseases. So then early referral is important rather than waiting Even they can come before 1 year, prior to 1 year. So then, even though they are coming earlier, so you have to attend them and start investigating and treating. So then there are investigations you have to perform. So first instance, you are not going to do all the investigation in the primary level. So you have to assess, first you have to assess their female partner ovulation. Ovulation assessment is very important. And then you can do, if there's any suspicion, some hormonal testing, like day 21 progesterone, thyroid hormone, and test for PID, that is chlamydial antibody. For example, taking swabs from the cervical cavity for that, it is called NAT, nucleic acid amplification test, because there's prevalence of the PID due to chlamydia is with more in the younger population, so then you have to do the testing for the chlamydia. In male, so we have to do the sperm analysis. So those are the primary level of investigations you have to do in the couple. But in the secondary level, once you still they are failing to get conception, then you have to assess the tubal patency, a laparoscopic assessment, and uterine abnormalities with the hysteroscope. So those are secondary level. So then you should know what are the primary level assessment and secondary level assessment. Clear? Is there any issue of my voice? Hello?
Also, it's better, sir.
Okay, fine. Okay, then the other important thing is, as I said, the ovulation is a primary important thing in the conception, and how we are going to assess the ovulation. There are several ways of assessing ovulation. The first thing is history. So if somebody having a regular normal menstrual cycle, so that will say that that woman is ovulating, but not 100%. But there are some instances, it is called luteinizing unruptured follicular syndrome. So usually this can happen in the endometriosis, in other some condition like somebody taking NSAID, like and other medication. So they can have regular periods, but they don't ovulate. But those are exceptions. But regular normal periods are evidence, is the evidence of ovulation. That is one thing. And then you know that the cervical mucus assessment. So usually towards the ovulation, that's mean luteal phase, cervical mucus get thinner and like a watery. But if it is in a follicular phase, thick and mucus-like. So if it is getting thinner and watery, so that is also evidence of ovulation. And then mid-cycle pain. So, but mid-cycle, you get mid-cycle pain only 10% of people. So, that is Luteal syndrome. Mid-cycle pain is one of the good evidence that human is ovulating. So, those are the three things that in history, so you understand that woman is ovulating. So, then investigation. So, serum progesterone. Serum progesterone. If it is more than 30 nanogram per liter, so that will say that will indicate that a woman is ovulated already. So you have to be careful when you are talking about previously we talk about the day 21 progesterone, but everybody don't get 28 day cycles. So because of that, so now the nomenclature is changed. So you have to tell that mid luteal progesterone. Some can have prolonged long cycles, like not 28 days, short and long cycles. But what you have to understand, their luteal phase is constant. Follicular, say the 35 day cycles, luteal phase is constant, that last 14 days. First 21 days is the variable time. So if somebody get 44 days cycle, their luteal phase, the last 14 days is constant, but the first 20 days, 30 days is the variable period. That is why we say mid-luteal progesterone. So we don't talk till now the 21-day progesterone. Then LH and FSH level. LH and FSH level is deranging, usually polycystic ovarian syndrome. There the ovulation is defective. And then there is another test called the dipstick test. So like pregnancy, during pregnancy test, so you can at home, like pregnancy test, you can do the urine sample, you can do this test. So there are two lines appearing. One is if there is a green light, a green mark appearing in the tip. So that means the urinary concentration of LH level is high. So that is why green mark is appearing. That is after surge of LH. So that will also indicate ovulation. So then somebody want to have time sexual intercourse. So then they can check whether they have crossed to the ovulation with checking LH level by dipstick. That is a home-based testing. So the best test to check the ovulation is serial ultrasound scan close to the ovulation. So usually we say that very nice follicle, developing follicles. So then when you are doing the ultrasound scan like on a daily basis, so then gradually you see that follicles get ruptured and ovulation happens, then ultimately replaced with corpus luteum. Corpus luteum will appear, collapse, small cyst-like. There are internal echogenicity, that is internal bleeding. So that is the best evidence to say that woman is ovulated. So then these things are very important because then you can have timing of this thing. You can advise them timing of sexual intercourse or whatever the interventions. So assessment of ovulation, history, and so history, regular based cycles, then with cycle A, and then investigation wise serum progesterone, integration, LH and FSH.
So excuse me, so it's not clear again. It's a bit
Hello?
quiet.
Hello.
Okay. Now.
You okay? You okay?
Yes.
Okay. Right. So then the investigations wise, sorry, investigations wise. So what we have to do is mid-luteal progesterone and LH and FSH level, dipstick test, during dipstick test to see that LH surge, and the best test is serial ultrasound scan to see the ovulation. So I talk about this thing, how to do serum progesterone in somebody having irregular cycles. So as I said, it is a last 14 days is the considered. So then you have to start 14 days onwards, weekly basis until she is getting the peak of serum progesterone, that is more than 30 gram per liter. So this is how to interpret nanomouse. This is how to interpret the serum progesterone level. So usually you remember, just remember 30, more than 30 is the proof of ovulation. Other tests like estradiol level and testosterone levels are specified. It is for the PCOS, not for sole purposes, not for the ovulation. Prolactin levels we will do in case of suspected pituitary adenoma. If somebody having symptoms like a severe headache, visual disturbances, galactoria, and prolonged uniform. Then thyroid test, not for all, but if you suspect thyroid dysfunction with thyroid gland enlargement, the better to do as a good practice thyroid function test is androgen profile is DHEAS and serum androstenedione levels are important in case of suspected late onset adrenal hyperplasia. So they will have oligomenorrhea or amenorrhea, defective ovulation. So then these tests are done in suspected case of late onset congenital adrenal hyperplasia. So I talked about this test. The better to do vaginal swabs before treatment and chlamydial screening, because so during subfertility treatment, sometimes you have to do intervention like IUI, the retrieval of oocytes and these things. So if there's a chlamydial infection, because of most of them are asymptomatic, so you can introduce, they can have ascending infection. Because of that, before any treatment, so better to do test for PID in subfertile. Another thing is, don't forget rubella is better. So you know that rubella is just a viral infection. It will happen in the first trimester of the pregnancy. There is a high chance, that's 80% of chance, the fetus gets severely damaged fetus and congenital abnormalities. So then, so you have to check whether they have immunity for the rubella. Basically, if they have evidence that they had a rubella immunization, that is okay. Otherwise, so if there's a doubtful history, check for rubella antibodies. So if they are not immune, ask them to have a rubella vaccine and avoid conception for 3 months. Any issue at the moment? So can you hear now? Still the voice is not clear. Hello?
Can follow, sir. It's fine, sir. We can
Right.
follow.
Then I talk about the cervical hostility due to antibody formation and mucus that prevent the sperm to travel from the cervix and damage. But usually we don't recommend at the moment post-coital. Previously we have done post-coital tests. Nowadays we don't recommend these tests to see whether there is a cervical hostility. Then the seminal fluid analysis, you have to know about the seminal fluid analysis, what are the quantitatively, what kind of referent ranges are there, how to collect the seminal fluid sample. Please, they have to have 3 days abstinence, and then better to collect in the laboratory, or if they collect from outside, they have to bring the sample within 30 to 60 minutes to the reference lab. So this is the latest reference limit of, according to WHO. They have changed the previous things, and they now adapted to these values. So you have to, at least you have to remember basic, what are the lower limit of reference, like the volume 1.5, then sperm concentration 15, motility as a 32, and sperm viability as a 58, and morphology at least more than 4. So these values you need to know, because sometime in the stations you will get seminal fluid analysis reports due to interpret. So this latest classification according to the WHO criteria, you need to know about the reference level. So secondary care levels, what are the investigation you have to do is tubal patency. So tubal patency, the most popular test is hysterosalpingogram. So you assess the uterine cavity and the tube, whether it is patent or not. So then, so basically you do HSD somebody with the history of normal periods and no pelvic pathology. But if you suspect any pelvic pathology with the dysmenorrhea, dyspareunia, and different kind of history, so then the investigation of choice is laparoscopy. and eye test and proceed. Because then you can diagnose any pelvic diseases which is not possible with the HSG, and with the laparoscopy at the same time you can treat them. So then the treatments, we are going to talk about the treatment. So you know that before starting treatment, so you have to assess the history taking, examination, investigation. You assess their ovulation, tubal, and the male sperm counts. So then the counseling is important with these investigations. So you have to tell what is their chance of conception. Then if there are any issues, so you have to refer them for the specialized care. As I said, lifestyle modification, weight reduction, and avoid smoking, alcohol, male partner. These general issues you have to address. So they have to. So you have to tell them to take folic acid, check rubella status, cervical screening. These things you have to counsel them prior to starting the treatment. So treatment basically depend on the primary cause for the subfertility. If you found primary cause, then if it is a hypogonadotrophic hypertension, you can do GMR. Then likewise, if they are human is having hypoprolactinemia, you have to give bromocriptine. So likewise, these things are specific management options. Okay, so this is important because usually most of the people have ovulatory dysfunction. So how you are going to treat? First line treatment is anti-estrogen. There are so many anti-estrogen, but for example, clomiphene and tamoxifen. So usually, so you can start with ovulation induction, that is called ovulation induction. So day 2 to day 6 of the cycle, then you arrange follicular tracking. That means to see whether they are ovulating in day 12 of the cycle. So then you know that with the clomiphene or tamoxifen, whether they are developing good follicles. So then what you have to remember is we should not give this kind of treatment more than 6 months at a stretch. But the recommendation is give up to 6 months and then wait for some time. You can give another 6 months, and maximum you can give is a 12 months period, because if you do more than 12 months, the natural conception rate is reduced because it is anti-estrogen, and there is a theoretical risk of chance of ovarian malignancy later on in their life. Then metformin is a drug that you can use as a facilitator for ovulatory dysfunction, for ovulation. But basically, you have to select the candidate. If they are having a high BMI and no response to clomiphene citrate after long cycles, then metformin for 6 months is one of the choice. So gonadotropin, that is FSH. You can give FSH injection to then to have follicles too. That is a follicular induction agent, gonadotropin. Then ovarian relief. So you know that in ovarian, the polycystic ovarian disease, so they can have lot of small follicles in the ovary. So these are toxic to gametes. So then in the laparoscopic ovarian disease, what you are doing is you are going to put some holes in these small follicles and release their content. So then in later on subsequent cycle, so there is a chance then to have more good quality ovum and ovulation chance is higher with the laparoscopic ovarian disease. Then if you found, if the woman is found to have endometriosis or adhesions, so then laparoscopically what you have to do is that you have to release the endometriotic adhesions and diatomize and do cystectomy. So that will greatly improve ovulation and subsequent pregnancy with the laparoscopic treatment for endometriosis. So tubal factor, there's somebody having tubal factor subfertility. So if the both tubes are blocked, of course there's no chance that to have a other form of treatment. IVF is the choice. But tubal, microscopic tubal surgery like cannulation and reconstruction can be done, but failure rate is much higher. Then uterine factor, if there's adhesion, so hysteroscopic adhesive lysis you can do. If there's submucous or fibroid, myomectomy will improve the fertility rate. Then the after ovulation induction, then what you have to do is next possible treatment option is intrauterine insemination. You just bypass vagina and cervix and directly inject process sperm to the uterine cavity. You can see in this diagram. So then it will go directly to uterine cavity. There is a 20 to 25% chance of single cycle conception. If you do for 3 cycles, if you do 3 repeat procedures, there is a 50% chance then to get pregnant with IUI. That is called intrauterine insemination. Then in vitro fertilization. In vitro fertilization is indicated for somebody not able to conceive after long-term treatment. There's a tubal factor infertility, tubal block. There's a male factor severe oligospermia or azoospermia. Then IVF is the best treatment option, but you have to remember it is very expensive. And but pregnancy chance is 30% with the one cycle. So then the ICSI is intracytoplasmic sperm injection with a single sperm directly injected the oocyte. Donor insemination is we use donor sample, that's mean donor oocyte donation. And if somebody is more than 40 years old, so that will subsequently increase the pregnancy chance. That is in vitro fertilization. Okay, right. So here, so I talk about the now 1 hour gone. So I talk about the subfertility. Basically, I talk about the subfertility. What is the definition? So how we are going to investigate them, how to assess the ovulation, what are the etiological factors, different modality of treatment for ovulatory dysfunction, then etiological wise how we are going to treat them, then tubal assessment, primary care level and secondary care level management, and so then other advanced reproductive technologies like IUI, donor insemination, oocyte donation, and ICSI. So those are the component of in vitro fertilization. So the subfertility management is in day-to-day basis, it is advanced, and there are so many other micro procedures which will improve and the fertility rate. So there are some drugs we can use, but at the moment, if you know these basic about fertility management, that is much more enough for your curriculum in the final MBBS. And so you have to go through your textbooks, have more understanding of what are the basics of the fertility and subfertility. And so, as I said, this is a major part in gynecology. So it is very important to know about fertility. And you can check your exam papers, MCQ, SBA, and SCA. There are so many questions regarding fertility, subfertility. So when you do your clinical appointment, so we are going to teach you much more clinical relevant things, and then you will see what are the practical involvement, and so on. So that is the end of my lecture. Do you have any questions? I don't think that you can ask at the moment, but so this is my first Zoom lecture. So if there's any issues regarding the sound, the disturbance and these things, I'm going to correct this next lecture. And but you have to tell me. So what are the issues while doing the lecture? Then with these issues, then I will correct in my next lecture. So thank you very much for joining with me for this lecture. and I will upload this lecture to the LMS. Then somebody wants to see again, you can go through. Okay, thank you very much and stay safe at home. Thank you.
Thank you, sir.
Thank you, sir.